This is Pediatric Metabolic Disorders Part 2. We're going to discuss two of the common disorders that are discovered on the newborn screen. The first is phenylketonuria. The problem with this disorder is that the children lack an enzyme that converts the amino acid phenylalanine to tyrosine. Elevated levels of phenylalanine causes permanent neurologic damage. It is excreted in the urine, and it gives the child a musty odor to the urine. The symptoms include delayed mental and social skills. The head size doesn't grow at the same rate as the long bones. The child may be hyperactive. They can have jerking movements of the arms or the legs, but it isn't actually seizure activity. There's mental delay and disability. They can develop a full-blown seizure disorder. They can have skin rashes as well as tremors. The foods these children need to avoid is quite lengthy, and when you look at it, you think, yikes, that's the majority of my diet. So eggs, milk, aspartame, which is the non-nutritive sweetener, meat, fish, and legumes, which would be beans, peas, lentils, etc. You have to remember that many of the carbohydrates also have protein. Bread is mixed with eggs. Desserts have eggs. Puddings have milk. So there's a lot of things that people eat that contain these products. So in the management of a PKU disorder is we contact the parents and let them know immediately that this child has PKU problem. Follow-up is mandatory, and the dietary modifications that these kids need to follow are for life. Certainly throughout childhood until they reach the age of maturity, and that's brain maturity as well, which isn't going to happen until they're really in their early 20s. And it's very important that they maintain these dietary modifications if they're planning to conceive and throughout pregnancy. The infants are put on a PKU-free infant formula, and Mead Johnson is one of the makers of this product. There are other formulas that are available for children as well as adults, and these formulas are supplements to a regular diet. They're not a replacement for regular food. The PKU levels are monitored as needed because some of these kids will tolerate more phenylalanine than others, and so they basically have to be followed and declare themselves as to their tolerance level. We monitor their growth and development, so that's going to be another part of your role, is to adequately and accurately measure their height and their weight and plot it on the growth chart. There are some medications on the horizon. Research is being done, and there's one called sopraterin. I'm not sure if that's exactly how you say it, and the brand name will be Kuvan. And what it does is it reduces the absorption of phenylalanine, so if they ingest something that they are not supposed to, they won't absorb it. But it's still in the FDA research tree. Our next disorder is congenital hypothyroidism. In my clinical practice, I have seen several children who have been victims of this disorder. And when you look at these kids, you can see the child on the left. His facies, meaning the way his face looks, is he has zero interest in what is going on around him. The child that's on the right has the typical clinical features. He has scrawny extremities, he has an umbilical hernia, his tongue is sticking out, and he also has an unusual facial appearance. Clinically, these children have poor growth because they're poor feeders. When you look at these faces, our description of it is called a dull facies. They do have a large protruding tongue. Their skin is scaly. Their hair is sparse and brittle, and it almost feels like a hairbrush. They can have cardiac issues in the form of bradycardia or heart block. Their skin is cold to touch. They're pale. They have severe developmental delay. And if we don't catch this by the time they're 6 months of age, this child will never be normal. They end up having physical and mental lethargy. So the congenital hypothyroidism signs and symptoms are in the category that is on the left side, on the younger. However, there is also acquired hypothyroidism that we find in older children, and these are your typical signs and symptoms of hypothyroidism as you would see in an adult. And what we might see is that a teenage girl does not get her period, or she starts producing milk, although she's not pregnant, nor has she delivered. Our nursing interventions include collecting lab tests and monitoring them, and we do thyroid function studies. For the newborn screening, we need a good heel stick, and it goes to the state lab. What we will find is that the TSH, thyroid stimulating hormone, is high, but the free T4 and the T3 are low. We repeat the TSH and the T4 usually every 6 to 8 weeks once we put the child on thyroid replacement. When the child is stable, the levels are repeated every 6 months, but what we must keep in mind in these very young children is they are growing rapidly, and so they are followed much closer than an older child. You can anticipate administering thyroid medications to these children whenever they're admitted to the hospital for another reason. Rarely do we admit these kids just because of hypothyroidism. So you'll be administering Levoxyl or Synthroid, and it comes as a microgram dose. Pharmacy usually will crush it and put it in liquid for the younger children, and for older children it's a small tablet. It's very important that the nurse obtains and charts an accurate height and weight measurement every time this child comes in. Other interventions include the parent education. They need to understand that thyroid replacement is a lifelong endeavor. They need to know how to give the accurate dose. They can't miss doses, and it's given every morning on an empty stomach. They don't put the medication in a bottle because if the kid doesn't finish their bottle, they didn't get their full dose. In addition, we want to teach them what the signs and symptoms of hypo and hyperthyroidism are, because as the child goes through a growth spurt, the thyroid dose may not be high enough, and so they'll exhibit signs of hypothyroidism again. Vice versa, when the dosage is increased, sometimes it's increased too much, and then the child will have symptoms of hyperthyroid. These children need office follow-up visits at least every 3 months until they're 3 years of age, and then every 6 months for older children. You should discharge these kids from the clinic with a lab slip and have them go to the lab a few days before the office visit. And that way, the pediatrician, endocrinologist, or nurse practitioner specialist have those labs to evaluate and make decisions for treatment. This ends part 2.